What's up, Ninja Nerds? In this video today, we are going to be talking about heart sounds. If you guys like this video, you benefit from it, it makes sense. Please support us, and the best way that you can do that, you already know the answer. Hit that subscribe button, hit that like button, and go ahead and throw some comments down in that comment section. Also, if you guys want some awesome notes, some great illustrations to follow along with during this video, go down to the description box below. It'll take you to our website where you guys can check that stuff out. Let's start talking about heart sounds. All right, so let's talk about heart sounds. When we talk about heart sounds, first thing we should understand is location. Where should we be listening for heart sounds? That's the most important part. And we can kind of correlate the location with the particular valve that we're trying to assess. So first things first, we have our diagram here. And what we're going to be looking for is what is the position that I should actually be listening to. In that position, which valve is actually the one that I'm evaluating. The way that you can remember that is the mnemonic, all physicians earn too much. Okay, so all stands for the aortic valve. So the aortic valve, you would particularly hear this at the right second intercostal space. So where would you hear this one? So if we have here's our first rib, here's the second rib, that would be the third rib. It's between the second and third rib. So right here would be my aortic valve sound. Okay, so that's going to be where I'm going to be listening for the aortic valve. And again, that's going to be the right second intercostal space. Physicians, so that is the pulmonic valve. The pulmonic valve, guess what? Just go to the other side. So on the other side, at this point here, on the left second intercostal space, is where I'm going to be listening for the pulmonic valve. So that would be the left second intercostal space for the pulmonic valve. The next one is Erb's point. So Erb's point is actually an interesting one. It's often the time where we actually listen for, it's a good overview of all heart sounds, and it's also a pretty good overview site for a lot of murmurs as well, especially like aortic regurgitation murmurs. So again, Erb's point is you just go down one more spot. So you got right second intercostal space, left second intercostal space, left third intercostal space would be your Erb's point, and that's going to be right here. Okay. Then we go to the next part, tricuspid valve. The tricuspid valve is actually going to be just one more below. So then go to the left fourth intercostal space. That will be the tricuspid valve. Last but not least is going to be the mitral valve. And the mitral valve is going to be located at the left fifth intercostal space. So you would likely be like, oh, that's just right here. No, we have to go to the clavicle and go right in the middle of the clavicle down to the left fifth intercostal space. So it actually should be about right here. And that will tell you all the locations that you should be listening at. So you should start off at the right upper sternal border, right second intercostal space, aortic valve, then left second intercostal space, pulmonic, left third, Erb's point, left fourth, tricuspid valve, left fifth, midclavicular line. That would be your mitral valve. All right, so let's just remind ourselves really quickly again for the sounds. Where are we going to be listening for them? So again, aortic valve, right second intercostal space. So right second intercostal space. And if you really want to be specific, we'll say a parasternal border, just on the side of the sternum, right? Then the pulmonic valve, we already hit this one hard, right? So this would be the left second intercostal space. And again, it's going to be that parasternal border. Then we have Erb's point, good overview for all heart sounds and murmurs. This is the left third intercostal space. And again, that parasternal border. Then you got your good old tricuspid valve, and that's going to be left fourth intercostal space. And that is again going to be the parasternal border. The last one to remember here, my friends, is that mitral valve. And with the mitral valve, we see this at the left fifth intercostal space at the level of the midclavicular line. So again, this would be the left fifth intercostal space, midclavicular line. That covers the overview of where we should auscultate, the valve that we're evaluating, and now let's talk about S1 and S2 heart sounds. All right, so let's start talking about the normal heart sounds, particularly S1, S2 heart sounds. What do they indicate? What are the valves that are actually closing? And then we can recap where we would be listening for in the location sense, okay? So first things first, we have what's called ventricular systole. So ventricular systole is when the ventricles are contracting, right? That's the simple terminology here is the ventricles are in their contractile stage, they're depolarized, they're electrically stimulated, and they're ready to just rock and roll and start blasting blood out of the ventricles. When that happens, you have to be thinking about the particular valves that are going to be closing. So generally, when the ventricles contract, the valves that you want to close is the tricuspid valve and the mitral valve. You want these to close because you want blood to only go from the ventricles into their respective arteries, the pulmonary artery and the aortic artery, right? In that situation, we don't want blood to go blasting back into the atria. So the tricuspid valve and the mitral valve should close. That is the indication of S1. So ventricular systole tells me about a particular heart sound, which is called S1. We'll talk about the second one a little bit later, which is called S2, respectively. But what I really want us to talk about is this S1. What does the S1 indicate? Well, it's the indication of the closure of the atrioventricular valves, that is the tricuspid valve and the mitral valve. Now, if we were to actually split these valves, now you can have split S1s, we're not going to talk about it though, but when you have and actually look at the S1, there is two sounds, but they're so close together that they sound like one sound. But what are that actual S1 sound indicating? So the red here is I'm representing the left side of the heart. That would be the closure of the mitral valve, okay? That's the closure of the mitral valve during systole. And then the blue is representing the right side of the heart. That would be the closure of the tricuspid valve during systole. So again, once S1 starts, from the point of S1 until the second heart sound that comes up, this whole period here is indicative of ventricular systole. It's that time period where the ventricles are contracting and pushing blood into the respective arteries. And then when the valves close, the mitral and tricuspid valve, it should give a nice little click sound or a lub type of sound. So oftentimes we'll use that terminology that this represents that lub type of sound. Now, sometimes it's difficult because when you're listening to the heart, you hear lub dub, lub dub, lub dub, lub dub. And when patients' hearts are going really fast, it's difficult to discern which one it is. Is it the lub that's the S1 or is it the dub? I can't really tell. So sometimes what you can do is you can palpate their carotids. When you're listening to their heart and you palpate the carotids, when you feel the upstroke of the carotid, the beat that's pulsating on your actual fingertips, that's the carotid upstroke. The carotid upstroke is kind of telling me that I am in the period of ventricular systole. And that will tell me that I'm correlating this with my S1 heart sound. So when you're listening to a patient's heart and you're feeling the carotid, the time that you hear lub should be around the same time that you feel the carotid upstroke, when the blood is rushing out of the ventricles. And then again, think about this anatomy-wise. When the ventricles contract, they push blood from the ventricle, left ventricle, into the aorta, and then up into the carotids. So you're gonna feel that rapid upstroke with the S1. It'll happen just right after the S1, and boom, you're gonna feel that, that's S1. If you feel it during the next part, which we'll talk about called the downstroke, that's S2. So now, we have S1. Let's go over here and talk about S2 now. So S2 is when the ventricles are done with their systolic time period. They're done actually contracting and squeezing blood. And it's time for them to start relaxing. So now they're going to start relaxing. When they relax, this is the time period where you want blood to actually go into the heart from the atria. So now we want the ventricles, when they're in diastole, we want them to fill with blood so that they can get ready, and whenever they contract again, they can push blood out. So in that case, I need the receiving chambers, the tricuspid valve and the mitral valve to open respectively for blood to come down into the ventricles from the atria. So I want the mitral valve and the tricuspid valve to open. The valves I do not want to open are what is the purpose of valves? To provide a one-way flow and to prevent backflow. That's their job. We do not want the aortic valve and the aortic valve and the pulmonic valve to stay open. We want these bad boys to close so that blood doesn't flow backwards into the ventricles. We only want blood coming into the ventricles from the atria, not from their respective arteries. And so what happens is when the ventricles relax, blood will actually kind of come backwards and recoil backwards going towards the ventricles and snap the aortic valve and the pulmonic valve shut. And that's where you get the S2 heart sound. So I already talked about this one, but this is your S1. And then again, from S1, which represents the onset of ventricular systole, and again, that's going to be closure of mitral valve and tricuspid valve. From that point until we get to this next heart sound here, I'm just color coding them respectively here. This is ventricular systole. Until we go now here, this is going to be your S2. This is S2 here, which is now the closure of the aortic and the pulmonic valve. This here. And there's a two component of there, just like there was a two component for the S1. There's a closure of two valves. What are these valves that are closing? The red one, which should come first, Just like in this situation, for S1, the mitral valve should come first because it's a higher pressure system that'll close first. The aortic valve is under higher pressure. It should also close first. And so because of that, S2 represents the closure of which valves? The aortic valve. And it also represents the closure of the pulmonic valve. And again, sometimes we refer to this as the dub type of sound, the second component. Now, we have this understanding that whenever there's ventricular systole, it's S1, closure of the mitral and tricuspid valve, correlating with the carotid upstroke. S2 is the onset of ventricular diastole, when blood is supposed to be running into the ventricles only from the atria, not from their respective arteries. And so because of that, it should actually snap the aortic valve and the pulmonic valve closed. That is the S2. And that should correlate with the carotid downstroke, because blood should be trying to recoil back to the heart, but we don't want it to go back into the heart, so the aortic valve closes. And so does the pulmonic valve. So again, this time period of ventricular diastole, which gives you the S2, this is correlated with the carotid downstroke. So that's what I really need you guys to remember, okay? So we've covered S1, ventricular systole, which is again telling me about closure of mitral valve and tricuspid valve associated with the carotid upstroke. Ventricular diastole, when the ventricles are relaxing. They should be receiving blood only from the atria, and the aortic valve and the pulmonic valve should snap shut to prevent blood from backflowing into the ventricles. So that's going to be S2. That should correlate with the carotid downstroke. Oftentimes we kind of simplify this into a lub for S1 and a dub for S2. But let's actually take a listen to what the normal heart sounds actually sound like. All right, so we talked about S1, which is ventricular systole, closure of the mitral tricuspid valve, right? Correlated with carotid upstroke. What we actually have to understand a little bit is that sometimes S1 may actually sound a little bit louder. In certain situations, we should understand that because they can test that on your exams. And also, you should be able to recognize this on a patient, but sometimes it can be softer, and we should be able to recognize if it's actually louder, if it's softer, being able to recognize that firsthand. And second thing, what are your differentials for having a loud S1, and what are your differentials for having a soft S1? So let's talk about that. A loud S1, there's three causes that I want you guys to remember. The three causes is there's some type of situation where the ventricles are in a hyperdynamic state. And what I mean is the more significant component of the S1 is the mitral valve, tricuspid valve to a smaller degree. But the mitral valve, whenever that thing snaps shut really hard, so you imagine having the valves like this and snapping them shut really hard, it's going to produce large vibrations, which will cause that S1 heart sound to be heard. So anytime the heart is just clanging and a banging, it is just hyper dynamic. That could be causing those valves to slap hard against one another, producing a very loud S1. So hyperdynamic states are a super important cause of having these very loud S1s. So what could be some hyperdynamic states? It's actually relatively simple. Think about patients that are having fevers or they're septic, right? If you're septic, sometimes in those states, your body's sympathetic nervous system is on overdrive, and it's causing your heart to pump harder and harder and harder to generate and push and meet all the demands of the body. Other situations is when your thyroid hormone levels are super high. So you know what they call that whenever your T3 and T4 levels are super high, that it's causing toxic effects in the body? Thyrotoxicosis. Other situations could be if a patient is exercising. If you're exercising, it's going to be causing those valves to be snapped shut really hard. Other situations could be in certain situations, like if a patient has very severe anemia. So very severe anemia could also do this. And other situations is where pregnancy is a really big one actually, because they have higher volumes and their heart has to pump really hard, because not only do they have to supply blood to their own tissues, they have to supply it to the little thing that's growing within them. So that's an important thing to think about. So in hyperdynamic states, just imagine this left ventricle is smashing blood that it's trying to push out of the aorta. But when it does that, it smashes these valves really, really hard shut. And that produces the vibration that will cause the loud S1. Okay, so hyperdynamic states would be a big one, and a relatively common one at that. On the lower likelihood of things that you could see, but definitely want to think about it, is in situations where the PR interval is really short. So when you have a short PR interval, here's what I want you to think about the PR interval. So you know that there's structures in the heart. You got your SA node, you got your AV node, you got all those bad boys. Here's your SA node, here's your AV node, and that's going down into your bundle branch system and then to your Purkinje. So the AV node, it receives electrical activity, says, oh, let me hold on to this electrical activity for just a second, because the whole purpose of it holding on to it is giving the ventricles enough time to relax, right? So you want to allow for the ventricles to go through diastole before you send electrical potentials down to it to cause it to contract again. People got to relax sometimes. So when your PR interval is short, your AV node's like, oh, hot potato, and it throws it down into the ventricles to depolarize. They don't get time to relax. And so because of that, with very short PR intervals, that decreases the diastolic filling time. Here's what I want you to think about. If you reduce diastolic filling, that means that there's a drop in the left ventricular in diastolic volume. There's less blood in the heart when it's relaxed. Okay, think about this. You have blood in the ventricles. Normally, when blood is in the ventricles, what it'll do is it'll try to push the actual, like imagine blood coming into the ventricles and filling, like it's filling up a cup. When it does that, it actually pushes the leaflets closer to one another as it fills. And so now if they're like at this distance, imagine these closing at here compared to here. Which one's going to produce a louder sound? If it's closer together or if they're farther together? It'd be farther away from one another, right? So the only way that they would be farther away from one another if there's not a lot of blood that's filling up to push them closer to one another. So that's what happens here. When there's a reduction in diastolic filling, there's less blood in the heart that it's not bringing the valve leaflets close to one another. And so if they're not close to one another, farther distance from one another. A farther distance from one another, when the ventricles contract, whoo baby, those are gonna slam shut because they're having to generate momentum. So that is the whole concept behind this, is that they're a farther distance of mitral valve leaflets. And this would be seen in what kind of condition would you have a very short PR interval? Wolff-Parkinson's White syndrome. That's why it's not super common. But definitely want to be thinking about it, okay? All right. The last one that I want you guys to think about is a condition called mitral stenosis. So mitral stenosis may cause a very loud S1, but we should actually categorize this a little bit more specifically. It's mitral stenosis that the actual valve, because in mitral stenosis, the valves get kind of like really fibrotic and less pliable and calcified, right? So in those situations, in mitral stenosis, we want to classify this more to like the mild to moderate category, meaning that they have still a little bit of pliability and a little bit of movement. If they're not moving whatsoever, they're not going to give you a loud S1. They'll actually cause a soft S1. Sometimes if it's a very severe, you may even have an absent type of S1. But in mild to moderate cases where there's still some pliability and movement of the valves, think about this. When your valve is super stenotic, difficult to be able to push blood through, the pressure inside of the atria increases because it has to accommodate for all of the volume that's sitting inside of it and all the pressure that's building up because it can't push blood down. So it's having a difficult time. It says, okay, the only way I'm going to be able to get blood down into the left ventricle is if I bulk up, get really hypertrophic, and generate high pressures and push blood down, right? So it generates these high pressures. So now think about the left ventricle. The left ventricle, it's now going to have to generate super high pressures because the only way that, if you guys remember back from the cardiac cycle video, how do we actually close the mitral valve? The left ventricular pressure has to be greater than the left atrial pressure. In order for that to happen, think about normally. So let's say normally. Let's just give an example here. Normal type of process. Let's say that the left atrial pressure is 10 millimeters of mercury. I'm just spitting some numbers here, right? That means that the left ventricular pressure would have to be greater than 10 millimeters of mercury to close the mitral valve. And that's the force, that's the amount of pressure that it's going to push on the mitral valve leaflets to close them. So that is the pressure that we need to close the mitral valve. Now, think about in someone who has mitral stenosis. Because of that stenosis, their left atrial pressures are way higher than normal. Let's just throw a number at it. Left atrial pressure is 30 millimeters of mercury. Now the left ventricular pressure is going to have to be greater than 30 millimeters of mercury for it to overcome the left atrial pressure to push the mitral valve close. It's going to hit that mitral valve, that poor little mitral valve is going to get hit with 30 millimeters of mercury or more. When you get hit with that high of a pressure, it's going to snap those valves closed if they have some pliability and give to them. And when they snap closed at that degree of pressure, imagine getting hit with a rock versus getting hit with a pebble. That's the kind of situation that's going to happen here. So in mitral stenosis, mild to moderate, where there is some type of pliability in the valves, and you're having to increase your left ventricular pressure to close the mitral valve because the left atrial pressure is high, that would cause a loud S1. Okay? So again, we got hyperdynamic states, we got mild to moderate mitral stenosis, and again, with that PR interval, again, I like to, if you could think about this, here's your valve leaflets. They're going to hang down if there's less blood to push them up. You see there's no blood in the ventricles that are pushing these leaflets closer to one another. If they're not as close to one another, they're farther distance, that's more momentum that they'll get when you have to close them shut. That's going to cause them to be louder. Okay, soft S1s. This is actually going to be the situation that's really interesting. And again, you know why this is actually going to be relatively easy? Because we already covered all the ones for loud S1. Guess what? Flip it. Flip it, baby. So in this case, to make our lives easier, because we've already understood this, so now it should be super easy to understand soft S1. In hypodynamic states, what would be a condition where you would have hypodynamic states, where your heart's not really pumping very much? It's not having high stroke volumes. Heart failure, right? That's a pretty easy one. So if someone has like a really significant heart failure, in situations of heart failure, what does that do? You're not going to be pushing on the mitral valve with as much force. And so since you're not pushing on the mitral valve with as much force, that's not going to close them shut as hard. And that's going to produce as loud of an S1. Soft S1s, it was a decreasing PR interval, my friends. So now it's have to be a long PR interval. So if the PR interval is prolonged, think about what that does. That does what to the diastolic filling time? Now remember, AV node, since it receives the extra electrical activity, it says, okay, I got to wait for the ventricles to relax. I'm going to let them wait. I'm going to let them wait. I'm going to let them wait. All right, here you go, ventricles. The ventricles have a lot of time to fill. So what does it do to the diastolic filling? It increases your diastolic filling. If they fill longer, that increases their left ventricular end diastolic volume. If you increase their left ventricular end diastolic volume, again, you're going to have more of the blood in these ventricles. Now imagine the blood's kind of like seeping around these valves here. What's it going to do to the valve? It's going to kind of lift the valve leaflets up. So now they're a closer distance than compared to that distance. If that's the case, then a close distance of mitral valve leaflets, what is that going to do? It's going to cause now, whenever the ventricle has to squeeze and push blood out, it only has to push in that small distance. What would be conditions where your PR interval is really long? Heart blocks, AV blocks, baby. Particularly, you may see this a little bit more commonly in like first degree, second degree heart blocks, but heart blocks would be one of them. Man, we're good. Mitral stenosis, what do you think would be a really bad one? Reflux. Or, you know, it's a mitral stenosis, could mild to moderate, but you know what else? It's actually really interesting. Sometimes very severe mitral stenosis. And that actually should make sense because if they're not pliable, they're very fibrotic, they don't move very much. If you only don't allow for them to move very much, they're not going to move during systole, and they're not going to move very much during diastole. So there's a very short distance, so it actually may be very soft. So you can actually add that one in there, severe mitral stenosis. But an easier one to remember here is mitral, oh, I done jacked up the name, mitral regurgitation. So why mitral regurgitation? Why would that do this? Well, it's pretty interesting. In mitral regurg, what happens is these valve leaflets are far away from one another, right? And that may seem odd, especially in these scenarios. But here's what I really want you to remember. When you're pumping blood from the left ventricle, you're supposed to be pumping it out into the aorta. Sometimes if you have mitral regurgitation, this valve leaflet, they never actually coapt together. You know, mitral regurgitation, you may have one of the valve leaflets. There could be many different reasons for mitral regurg, but the leaflets aren't coming close to one another, right? And that's one of the reasons why blood is regurgitating back in, because the valve leaflets aren't touching. So if that's the case, if they're not actually coming close together, this kind of connection isn't happening, they're not sealing very well, that's going to obviously cause blood to backflow into the left atrium. But also, if they're not smacking one another, do you think you're going to give yourself a very loud type of S1? No. So because of that, there is no good seal between the leaflets. So there's no good seal between the leaflets, so they don't actually slap together. And that's one of the important things to think about. There's no good seal between the leaflets. And if there's no good seal, they don't produce a sound. There's going to be not very much sound because they're not going to slap together. There's one other thought process. In mitral regurgitation, right, the blood that goes from the left ventricle goes back down where? From the left ventricle to the left atrium, we're pushing blood into the left atrium. It's going to flow right back down into the left atrium, right? That's the whole process. So in patients with mitral regurgitation, not only are the valves not going to form a good seal, but also every time we push blood into the left atrium, it's just going to flow right back down to the left ventricle. If all of that blood is in the left ventricle now the left ventricle is going to get volume overloaded. And now imagine these leaflets that are sitting on top of that blood column. They're sitting on top of the blood column. If all that blood is kind of sitting there, what is it doing to the leaflets again? It's bringing them closer together. So it's the same concept here. So if that's the case, they get high left ventricular end diastolic volumes, which is going to cause a small distance between the leaflets. And again, that is a problematic issue because now if you have all this blood that's accumulating, because every time the left ventricle is supposed to pump blood into the aorta, it pumps it up into the left atrium and then back down to the left ventricle it goes. It's just going to keep getting more and more and more volume, and that's going to accrue, and then bring the leaflets closer to one another. That's a short distance. We know short distances, you don't get a lot of momentum. It's going to produce a soft S1. All right, so let's talk about the S2. So S2 is obviously again, it's telling me about ventricular diastole, right? It's the period of when the ventricles are relaxing. It's whenever they're filling with blood. And whenever we want them to fill with blood, we only want it to come from the atria. We don't want it to come from the arteries that they just pushed the blood into. So those valves that they push the blood into should actually shut, right? So we should shut off the aortic valve, shut off the pulmonic valve. That is your S2, that is the dub, and that's associated with a carotid downstroke. Now, we can actually have, just like S1s, we can have loud S2s and soft S2s. Now, what could be the reasons for that? Well, it's for the most part, it's relatively simple. You want to think about loud S2s as though there's high pressure within the respective arteries that we just push blood into. So if we have, for example, let's say the pulmonary artery. So here's our valve here inside of the pulmonary artery. If we have some type of high pulmonary artery pressures, so the high pulmonary artery pressures, that high pulmonary artery pressures, think about having high pressure in this circuit. Okay, think about having high pressure in this circuit. When you push blood from the right ventricle out into this circuit here, right? When you push blood into it, it receives the blood, it kind of is elastic, it accommodates it, and then it should recoil and push the blood out into the respective circulations, but some of it should come back down, and that's why we got those good old valves to snap shut and to prevent the backflow. Imagine having such a high pressure system which is pushing down on you. So imagine I got this pressure on my back, right? I push blood out, and then now I have all this pressure in the pulmonary artery. It receives it, it recoils and pushes down. When it pushes down with a lot of force, and it snaps that pulmonic valve shut very hard. So again, high pulmonary artery pressures are going to shut the pulmonic valve very hard. And that is going to produce that loud S2. And so you would see this in any condition where there is what's called pulmonary hypertension. And there's many different causes for pulmonary hypertension, right? That's past the scope of this lecture. But again, thinking about this can help you in your diagnosis. So your very loud S2, more particularly like the pulmonic component, so you'll be listening more in that left upper sternal border maybe, you should be thinking about pulmonary hypertension. But if you have a loud S2 and it's due to the higher pressures that are actually occurring within the aorta. So this would be hypertension. Nothing crazy about it, right? So you have systemic hypertension. We'll call this systemic hypertension. So you have systemic hypertension. This is going to have your high pressures in the aorta. So the high aortic pressures. When you push blood from the left ventricle into the aorta is going to recoil, and then it's actually going to expand, accommodate that volume, and then recoil and push it down into the descending aorta, push it up into the branches off the aortic arch, all of that stuff. But when it does that, it's going to push some of the blood back down. And when it pushes some of these blood back down, it's going to really slam that aortic semilunar valve closed. So it's going to shut the aortic valve very hard. And again, when that happens, it's going to give a very loud S2. And again, this would be in situations of systemic hypertension. That would be things to think about, right? There could be other issues, corrected aorta, things of that nature as well. But big thing is the easiest one to remember, systemic hypertension, okay? So you hear loud S2s, you think high pressure within the aorta, high pressure within the pulmonary artery. Boom, roasted. Soft S2. This is actually going to be an interesting one where, again, S2 is the closure of the pulmonic valve and the aortic valve. Now, soft S2 is actually relatively difficult to hear with respect to the pulmonic valve, just because pulmonary stenosis isn't a super common type of occurrence. But with the aortic valve, it is actually the most common type of valvular disease. So imagine somebody has aortic stenosis, right? They got aortic stenosis, and this valve is just super calcified. It is just fibrotic, it's sclerotic, it's super immobile, and just doesn't want to allow any blood to be able to go through it. So its ability to open stinks, and its ability to close stinks. It's not very good at being able to open or close. Now think about that. Imagine the valve is like this, right? It's super stenotic and fibrotic, right? You got a small little space there. You try to push blood through it, it barely opens and lets blood go out. And then whenever you want it to close, it only goes like this. It doesn't actually come close to one another and actually snap really tightly together very well. So sometimes you can get kind of a stenotic and regurgitatic murmur. So again, imagine the valve is like this. It's very little orifice. You're trying to push blood open, it only opens up a little bit. And then when you close, it only has to close that small distance. So that's a short distance if it does close. And so in situations like that, this is where you may see soft S2s. So again, in this situation here with the soft S2, there may be again, less pliable valve, in this case, the aortic valve. That less pliable valve is not opening well and not closing well. And because of that, if it doesn't close very well and it doesn't close with the nice force that you would like it to, is you think that if I go from here to here, that's going to give me a loud sound versus from here to here. So again, not closing well will give you that soft type of S2. And the condition that you would see a lot of this in particularly is going to be aortic stenosis. You may see this in pulmonic stenosis, but it is way less common. And again, you can differentiate these by particular maneuvers, but also just location. Aortic should be right upper, pulmonic should be left upper sternal border. Okay, we've talked about the S1, S2 heart sounds. We talked about the changes in intensity of them, soft and loud. Now let's go into the S2 a little bit more, because what we haven't really talked about is that S2, there's two components that are easily able to differentiate: the aortic component, so the closure of the aortic valve, and the pulmonic component, the closure of the pulmonic valve. And sometimes we can actually separate those sounds really well, and they call that splitting. So we should be able to talk about that now, called the splitting of the S2 heart sound. All right, so now we're talking about the splitting of the S2 heart sound. So this is an interesting concept. So whenever you're listening to the heart, you hear the lub-dub, 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 right? So S1, S2, S1, S2. And again, ventricular systole, ventricular diastole, ventricular systole, ventricular diastole. It's the whole concept. But you know what's really interesting is that when you look at the dub component, the S2 component of the heart sound, the closure of the aortic and the pulmonic valve, sometimes there's certain ways and certain pathologies by which that heart sound actually for S2 can become split, where you can actually hear both the pulmonic component and the aortic component separately, not as one entity or one particular S2 heart sound. And that is called the splitting of the S2. So this can be physiological, and we'll take a listen here in a second, but what is the physiological split S2? All right, so whenever somebody is expiring, what is happening to the blood flow to their heart? Well, in this situation, whenever there's expiration, you got more blood flow coming via the pulmonary circulation into the left atrium, and then when it comes into the left atrium down into the left ventricle, you have more blood that's going to be filling into the left side of the heart. The left ventricle already contracts a lot faster, and it contracts with a higher pressure, so that's not going to be a problem. It's going to push blood out via the into the aorta, out into the systemic circulation, and when it pushes the blood out into the systemic circulation, into the aorta will receive the blood during systole, and whenever it does that, it'll recoil and smash blood out into the systemic circulation. Some will go back down towards the left ventricle and snap shut the aortic valve. the same kind of thing will happen, but there'll be more blood flow onto the left atrium, and during expiration there'll be less blood flow into the right ventricle. The right ventricle is a smaller pressure system. It takes a little bit longer to push blood out of it though too. But since there's less volume of blood coming into the right ventricle, it's going to be able to pump blood out into the pulmonary artery relatively easy. It can push it out, and then whenever it pushes the blood out into the pulmonary artery will receive it, recoil, send it out to the pulmonary circulation. Some will go back towards the right ventricle, snap the pulmonic valve shut. But since this is kind of occurring in a way where you get more on the left side and less going on the right side, it actually causes these sounds, just because the left ventricle contracts really quickly, it causes the sounds to become very close to one another. It's very difficult to differentiate. And so when you're actually looking at this on a graph here, so this is time, and we're looking at the S1 and S2 heart sounds. S1, this is S1, right? So that's the closure of the mitral and the tricuspid valve. Then you have the period of ventricular systole until we get to the point where the aortic valve and the pulmonic valve closed. The red component here is the aortic valve. We're going to put A2. So this is the aortic component of the S2 heart sound. And then the blue here, which is actually less intense. So intensity we could actually say is the y-axis, or pitch. This is your P2, which is the pulmonary component of the S2 heart sound. It'll come just a little bit after it. And again, intensity-wise, the A2 is higher intensity, a little bit louder than the P2. P2 a little bit less intense, a little bit softer than the A2. But again, they're so close to one another that we actually can't differentiate them from being separate from one another. Here's where it's interesting. During inspiration, what happens to the blood flow to the heart? During inspiration, you get a lot of blood flow coming into the right side of the heart. Like a lot of blood flow. Because what happens is during inspiration, what do? You take a deep breath in, your intrathoracic pressure decreases, and you suck blood into the right side of the heart. More blood goes into the right atrium and into the right ventricle. During inspiration, less blood is going from the left atrium into the left ventricle. So you're getting way more venous return to the right side of the heart, and you're getting less venous return to the left side of the heart. Which side takes a longer time to be able to push blood out? The right side. Now you fill it with more blood. It's going to take an even longer time. So what happens is during inspiration, you drop the intrathoracic pressure. And when you drop the intrathoracic pressure, that causes increase in right-sided filling, and that prolongs the right ventricle contraction. And that's going to cause the P2, which is the pulmonic component, to come a lot later than you'd want it to. So now look here, they were so close to one another, but now the right ventricle is getting overfilled. It's taking a little bit more time. Look, you split them. And so now you'd be able to hear the A2 and the P2 as a separate component only during inspiration. The whole purpose behind this is because whenever you take a breath in, you drop your intrathoracic pressure, suck blood into the right side of the heart, more blood on the right side of the heart, more volume that the right ventricle has to deal with. And it's going to take a longer time for the right ventricle to depolarize, contract, and push all that blood out into the pulmonary artery. As it takes a longer time to push blood into the pulmonary artery, it's going to take a longer time for it to receive it, accommodate it, and then recoil and snap the pulmonic valve shut. By that time, the aortic valve is closed a long time ago. And that is called the physiological splitting of the S2. It's pretty cool, right? And again, you only see this during inspiration. It's completely normal. What is not normal is when you have a wide split S2. A wide split S2 is where you actually have the splitting of the S2. There's the splitting of the S2 already present. So you can actually see here that during expiration, you have an A2 component, which is audible and differentiated from the P2, okay, during expiration. Okay, you have that differentiation factor there. You can hear that during expiration. During inspiration, something really interesting happens, right? So during inspiration, again, you get more blood to the right side of the heart, right? So it's the same concept. During inspiration, you're going to drop your intrathoracic pressure. You're going to increase your right side filling, and you're going to delay right ventricular contraction. And if it takes a longer time for the right ventricle to contract, it's going to take a longer time for it to pump blood out into the pulmonary artery, a longer time for the pulmonary artery to accommodate that, a longer time for it to recoil, a longer time for the pulmonic valve to close. So it's going to come later, way later. So you see how it's split during expiration? It becomes even more exaggeratingly split during inspiration. So there's a splitting that's present during expiration and even wider split during inspiration. Why? What is causing this? Well, the reason why it's happening at expiration and during inspiration is that there's something already previously wrong with the right ventricle. There was probably something here previously where the right ventricular afterload was already high. And so it was taking a longer time for blood to get pumped from the right ventricle into the pulmonary artery. So what are some reasons why it would already take a long time, and then you filling the ventricle with even more blood would even prolong the time even more? Right ventricular afterload is increased. There's a high right ventricular afterload. This could be due to pulmonary hypertension. If you have pulmonary hypertension, the pressure in here is higher. It's going to take a longer time for the right ventricle to pump blood out into the pulmonary trunk. And if you have it get filled with more blood, you're even going to prolong that time even more. What if you have a pulmonary embolus? Now you got a clot that's sitting here in the pulmonary artery. That's going to increase the pressure. Again, your right ventricle is going to have to take a longer time to generate enough pressure to push blood out. That's going to delay it, and it's going to be even worse during inspiration. What else? What about pulmonic stenosis? If you have pulmonic stenosis, where you have a terrible pulmonic valve and it's really, really stenotic and it's not really wanting to open. If it doesn't want to open, now your right ventricle is going to have to get thicker. It's going to have to work hard. It's going to have to generate more pressure to push blood out of the pulmonary out into the pulmonary artery. That's time, and that gets worsened during inspiration. What else? What if I actually cause delay of the right ventricular depolarization? So not only do I cause the afterload to be higher, but I cause the depolarization. You know, there's the structures here. Your good old SA node, your good old AV node. Then you have your bundle of His, then your right bundle branch, and your left bundle branch. What if I knocked out my right bundle branch? What if I damaged my right bundle branch, and now it can't supply electrical activity to the right ventricle, so it takes a longer time for the right ventricle to actually depolarize? Ooh, that would make sense, right? So what if I prolong right ventricle depolarization? So I prolong it. That would be a right bundle branch block. And if I have a right bundle branch block, it's going to take longer for the right ventricle to depolarize. It's going to take longer for it to contract, longer for it to push blood into the pulmonary artery, longer for it to recoil and shut that valve. Man, we good. But let's take it to the next level. What if not only is this a problem with the right side of the heart, what if I took it to the next level and I said, what if my left ventricle depolarized early? I depolarize it early, I cause it contract early, I cause it to push blood out even faster than it already is doing. That's going to separate it away from the P2, right? What would do that? What would actually cause this beautiful left ventricle to depolarize a lot quicker? I'm so glad you asked. If we increase left ventricular depolarization, okay, so I'm going to put down we increase left ventricular depolarization, and we do that quicker or earlier, then I'm going to have electrical activity moving through the left ventricle, stimulating the left ventricle first. And if it depolarizes the left ventricle first, it'll contract early, push blood out into the aorta early, cause the aortic semilunar valve to close earlier. This would be a condition where there's an accessory pathway running right into the left ventricle via the bundle of Kent. This is the situation called Wolff-Parkinson's-White syndrome, and we particularly call this type A, where the bundle of Kent is located between the left atrium and the left ventricle. Man, we good. So this is what I want you guys to remember, again, in patients who have wide split S2. They naturally have three things wrong. One is their right ventricular afterload is high, causing them to take a longer time to be able to push blood out of their right ventricle. The right ventricular depolarization is prolonged, taking a longer time for them to contract and push blood out of the right ventricle. In that situation, it's already going to cause the P2 to come later, regardless of expiration or inspiration. But during inspiration, you bring more blood into the right side of the heart, you cause a larger volume that the right ventricle is going to have to deal with. So if they have a high afterload and they have a longer depolarization period, now it's going to take even longer time for it to push blood out. And that's going to cause that P2 to come even later. The other situation, which seems a little odd, but it's kind of like a little extra one to think about, is what if I cause the, I cause the left ventricle to depolarize a lot earlier than the right ventricle. So that would kind of just go against this in a weird way. If I depolarize my left ventricle early, it's going to contract earlier, push blood earlier, close the valve earlier, and so it might shift the A2 where it looks like the P2 was the one that was drifting away, but it was actually the A2 drifting away. And so you can see that in this situation of Wolff-Parkinson's-White syndrome type A. Okay, we covered a behemoth. Let's now move on to the next one, which is called the fixed split S2. So fixed split S2 is a very interesting one. So a fixed split S2 would actually be where the splitting of the A2 and the P2 component during S2 is the same distance regardless if you're expiring or inspiring. It doesn't matter. It's the same distance. It is a fixed distance or separation or differentiation or distinction between the A2 and the P2 component. And it's not changing. So look at this. Look at this. You see how during expiration, the distance here is the exact same as the distance here. That is weird. How can the A2 component and the P2 component be the exact same distance during expiration as it is during inspiration? Well, that means that there has to be some type of communication between the heart, an abnormal communication that is equalizing a lot of the pressure and the transit time in and out of the heart. What kind of communication would that be? I'm so glad you asked, because it's actually called an atrial septal defect. So you know in patients who have something called a atrial septal defect, there's a hole in their atria, right between the interatrial septum. During expiration, which side is actually getting filled more? During expiration, which side is getting filled more? You should have left-sided filling. So during expiration, imagine there's the pulmonary veins here. You should get blood that's filling into the left atrium and down into the left ventricle. That's what should happen here, right? But think about this also. During expiration, you get more blood to the left atrium. Which side has a higher pressure? Left atrial pressure or right atrial pressure? Left atrial pressure. Left atrium, left side, it always has higher pressure. So the left atrial pressure versus the right atrial pressure, you're going to have much higher left atrial pressures, even in normal patients, no matter what, than your right atrial pressures. This should be lower. So because of that, where would the blood want to go? It has an opportunity to go down into the left ventricle, but it also has this other area where it can go where there's less resistance. Left atrium to right atrium, lower pressure system. It's easy for blood to flow from areas of high pressure to areas of low pressure. So where else can the blood go? It can go right into the right atrium. And then the right atrium is going to get filled with blood. Okay? And so it's going to get a little bit more blood than it usually will. During expiration, what happens to the venous return on the right side? The venous return on the right side is reduced during expiration because your intrathoracic pressure is generally going to be higher and it's harder to suck blood up into the right side of the heart. So during expiration, there should be a reduction in venous return. So let's just actually represent that as just like one arrow moving down from the right atrium into the right ventricles during expiration. So there's a reduction in right filling during expiration. That's a normal process. Lower reduction, there's a reduction in right-sided filling. But there's blood coming from the left atrium via the atrial septal defect, increasing the filling. So you got 3 arrows there, okay? So 3 arrows there, which are gonna represent the splitting. So now if I have more volume of blood in the right ventricle, there's more volume. More volume of blood in the right ventricle is going to take a longer time for the right ventricle to depolarize, a longer time for it to contract, a longer time for it to push all that blood out into the pulmonary artery. Pulmonary artery has to accommodate, it has to recoil and push the blood back down and shut the pulmonic valve closed. That's time it's going to take, and the left ventricle is going to finish that before it. All right? That's why it'll come later. But here's where it's interesting. It'll stay the same, it'll still increase, there'll still be a splitting, but it's going to stay the same in like same width. Why? Okay, during inspiration, what happens to the filling on the left side of the heart? During inspiration, you should get less filling into the left side of the heart. So there should be less blood that's coming into the left side of the heart. Regardless though, left atrial pressures are going to be higher. No matter what, right atrial pressures are going to be lower. But here's the thing. You have less blood coming into the left atrium during inspiration. Less blood coming into the left atrium during inspiration. So maybe because of that, you're not going to have as much blood to push from there's still higher pressure here, so I can still push blood from the left atrium to the right atrium. But because I have less volume of blood coming from the lungs to the actual left side of the heart, I don't have as much volume of blood to donate to the right atrium. But I push a little bit over. So now I push a little bit over, and let's represent that with one arrow that I put some blood into the right side of the heart due to the ASD. Okay? So again, this is the ASD that we're talking about here, an atrial septal defect. But during inspiration, what happens to the filling to the right side of the heart? You increase the right heart filling. So now during inspiration, you should have higher right heart filling. So more blood should come into, so you have inferior vena cava, superior vena cava, you're going to have more filling here. And let's represent that. We only had one arrow to represent the right heart filling from expiration. During inspiration, you're going to get more volume of blood, and so you should have an increase in venous return to the right side of the heart. There's 3 arrows. How many arrows did I represent? I know it's not a matter of arrows, but it's the whole principle here. I'm getting, during expiration, more blood coming from the left side of the heart to the right side of the heart, and less venous return during expiration. During inspiration, I'm getting less blood coming from the left side of the heart and more blood that's being filled into the right side of the heart during inspiration from venous return. But either way, the number of arrows is the same, because no matter what, regardless, there's a communication between the atria that is allowing for this kind of equalization of right-sided filling. But either way, the right side is going to take a longer time to be able to contract, a longer time to be able to push blood out of the right ventricle into the pulmonary artery, a longer time for the pulmonary artery to accommodate that, recoil, and snap the pulmonary valve shut. And it's going to cause it to come later than the A2. But it's a fixed distance. It's the same during expiration and inspiration because of the way the blood is moving across the left atrium to the right atrium during expiration and inspiration varies. And that's the cool part. And the amount of blood that's coming into the right side of the heart during expiration and inspiration varies, but they equal each other out in a way that it keeps the distance the exact same. How cool is that? All right, let's now move on to the next one called paradoxical split S2. All right, so let's talk about paradoxical splitting of the S2. So this one's an interesting one. So it's paradoxical in the sense that A2 should generally always come before the P2, right? The left ventricle contracts quicker, it's under more pressure, it's gonna push blood out into the aorta a lot quicker, close the aortic valve a lot quicker. That's a general concept that we've been able to pretty much assume throughout all of these splitting of the S2s. It's always come before the P2. What if there's some situation where the actual A2 comes after the P2? That's odd, right? That would be really odd. That would mean that the left ventricle is taking a super long time to be able to contract and push blood out into the aorta. So there's something that's causing the afterload, just like in the other situation where there was a wide split S2. There's got to be something in the same situation where the left ventricle has a high afterload. It's having a difficult time pushing blood out into the aorta, or the depolarization of the left ventricle is being delayed, or the right ventricle is being excited early. So just flip it. Whatever it was for the wide split S2, flip it, and that's going to be for the paradoxical splitting S2. It's just for the left ventricle now. So what were those situations we said? The left ventricle is going to have a tough time pushing blood out into the aorta. So that would be one particular reason where there is a high look, I already got it in my head, a high left ventricular afterload. So there's a high left ventricular afterload. What would be particular situations for this? What if I have a good old stenotic valve here that doesn't want to allow me to push blood out? Aortic stenosis. What if I have really high pressure in the aorta and it's not a big fan of me pushing blood out there? This could be hypertension, so systemic hypertension. Or what if there is a really tiny narrowing? There's a narrowing of the vessel in very congenital heart diseases where the aorta is actually coarcted or has a little narrow stenotic point. Coarctation of the aorta. In these situations, it would take longer for the left ventricle to build up enough pressure to push blood out into the aorta because the pressure in the aorta is way too high. Simple, right? Not too bad. And if that happens, it's going to cause the actual A2 component to come a lot later. It's going to come a lot later during expiration, and it's going to come a lot later during inspiration. Okay, but we'll make sense of why maybe it's a little bit more during expiration. Don't worry, we got you. All right, Next thing here, what would else be the other reason? The other reason is we said that not only would be higher afterload, but the left ventricle is having a decrease, its depolarization is coming later. It's prolonged depolarization. So we said that there also could be a prolonged depolarization of left ventricle. So it's taking a longer time for us to be able to get the left ventricle depolarized. So think about that structure stuff that we talked about before. Here you got your SA node, here you got your AV node, here you got your bundle of His, your right bundle branch, your left bundle branch. The left bundle branch is giving the electrical activity to the left side of the heart. What if I jack that bad boy up? I cause damage to that left bundle branch, and now it couldn't excite the left side of the heart as easily. It's going to take a longer time for it to depolarize now, right? So in that situation, this would be due to a left bundle branch block. Man, we're good. All right. The last scenario here is that we said, what if there's some type of weird ability to stimulate the right side of the heart faster for it to actually depolarize quicker? So what if there is a quicker depolarization of the right ventricle? So a quicker depolarization of the right ventricle. So if I have electrical activity that moves from the atria down into the ventricles, particularly the right ventricle, and then it can go back and excite the right ventricle and cause it to depolarize quicker than the left ventricle. So now the right ventricle contracts earlier, pushes blood out of the right ventricle earlier, into the pulmonary artery earlier, closes the pulmonic valve earlier. That's kind of the same thing where it seems like the pulmonic valve is actually coming earlier than the aortic component. That would be a situation where you have Wolff-Parkinson's-White syndrome, but the rare type, type B, where the bundle of Kent is actually associated between the right atrium and the right ventricle. Not a common one, but it's something to think about. All right, so that's the concept here. That's the reason behind this paradoxical splitting S2, why the A2 component has to come after the pulmonic component. But let's see how it changes during expiration and inspiration. During expiration, what are you noticing here? Ooh, wow, it's wider. It's wider during expiration. Let's think about why that is the case, my friends. During expiration, which side of the heart gets filled more? The left side. So during expiration, there's increase in left-sided filling. If I have more blood coming into the left ventricle, and it's already taking a longer time for it to actually contract and push blood out, it's taking a longer time for it to depolarize, what do you think that's going to do? It's going to have more volume on top of these issues. It's going to prolong the distance between the P2 and the A2. Man, we're good. And during inspiration, there is a reduction in the left-sided filling. And so that means that there's less blood that's going to come into the left side of the heart. But there's still these issues where the left ventricle is under high afterload, or it's taking a long time to depolarize and contract. We're good, right? And so that's the important thing to remember here is that, again, A2 comes later and P2 comes earlier. But the big difference here is during expiration, there's an increased separation because you get more filling to the left side of the heart, which is going to prolong the ability and the time it's going to take for the left ventricle to push blood out because it also has these associated issues. Man, we're good. All right, absent split S2. Absent split S2 is another interesting one. It's sometimes just called a single S2. And it's where you get no splitting. All right, so you should normally have splitting of the S2. But when you have no splitting of the S2, this is something that's very interesting. You know a patient who has very, very terrible, and I'm talking about like the most severe type of aortic stenosis, where their valve is so stenotic, the dang thing doesn't even want to move at all and allow blood to go out. It doesn't want to allow blood to go out at all. So it's super, super, super stenotic. Like think about the most severe case of aortic stenosis. So in severe cases of aortic stenosis, where it's super impliable, it's very, very immobile. So severe aortic stenosis. Super, super calcified, fibrotic, not pliable, very immobile. When I want to push blood from my left ventricle out into the aorta, right? You'd think about this a little bit. You'd say, oh man, wouldn't that really increase the afterload? It definitely could. But here's the thing. You have to have two components, or you have to have an actual closing of the valve. You need a closing of the valve to actually produce an aortic component or a pulmonic component. So you would think, oh, wouldn't this just kind of like, be the same thing as a paradoxical splitting of the S2 where it would come later? It would if you actually could hear that sound. That's the key thing. So imagine you push blood up from the left ventricle into the aorta. The aorta has to accommodate it, recoil, push the blood out into the systemic circulation, and then some of it will go back towards the left heart. When it goes back towards the left heart, what do you want the aortic valve to do? Snap shut. But in a situation where that valve is so immobile, so fibrotic, so calcified, not pliable whatsoever, you have blood come back. Imagine hitting that valve and the thing doesn't even do anything. It doesn't even close. Normally, if you have some type of aortic stenosis, there's some pliability. It'll actually at least snap shut and give a sound. But if that thing is so fibrotic and so calcified to where you come back and cause blood from the aorta to push back down to snap it shut, it doesn't even move, it doesn't snap together, you're not going to get any hit of the aortic valve leaflets, no vibrations that are going to cause a sound. And so this severe aortic stenosis in these patients, they have no like actual true closure of the aortic valve. And so because of that, all you're going to hear is the P2 component. So all you'll hear for these patients is the P2 component. You won't hear the aortic component. If it were to be there, it probably would come later, like a paradoxical splitting of the S2, because it's going to increase the left ventricular afterload. But if you can't actually have the valve close and give a sound, you're not going to get any splitting of the S2 and no actual A2 component in comparison to the P2 component. So this is a big thing to remember. Very, very severe aortic stenosis where there is very like fibrotic and immobile aortic valve. This is where you would see this. Okay, my friends, we've covered all the splitting of the S2s. This is a beast. So let's go ahead and test your knowledge quick. So let's test your knowledge. Let's take a look at these and being able to point them out. That's gonna help you guys to really kind of like recap what we talked about, because it was a lot, I'm not gonna lie. All right, so we take a look here. Expiration, inspiration is represented by the E and the I. Okay, you take a look here. P2 component. Why is the P2 component early? Normally it's always supposed to be what? A2 component early. But the P2 component came early. And it's more distance during expiration. That was the weird one. What was that one called? This is the paradoxical splitting of the S2. So don't forget that one. Paradoxical splitting of the S2 is where the P2 comes early or comes before the A2, and there's an increase in the distance or splitting of the S2 during expiration. All right, take a look at the next one here. Expiration, inspiration. During expiration, okay, the P2 is coming forward. It's coming, I'm sorry, the A2 is coming first. So if the A2 is coming first, that's normal. There's no paradoxical stuff there. So that rules that one out. The P2 is coming later, which is good. But look at the distance. The distance between these is pretty much the same. So at the same distance. So because the distance between these are the exact same, it is a fixed distance during expiration, inspiration. That would be, which type of situations? That would be the fixed split S2. Okay, so with the paradoxical, that was high left ventricular afterload, a longer period of left ventricular depolarization, or early excitation of the right ventricle. For fixed split, it had to be a what? Atrial septal defect. Okay, we come over here. We have expiration, inspiration. Again, we have our A2 first, which is good. We have our P2, but it's actually like fused with it. So we have like no true splitting during expiration. During inspiration, we have splitting. Well, that had to be the only one where it's actually like, again, close together during expiration. That's normal. There's no actual pathology there. And during inspiration, it actually causes the splitting to occur. That has to be the physiological split. So we'll put physiological. So this is the physiological split. S2. All right, beautiful. Last but not least, we take a look here, and we only have like one of these big ones left here. Expiration, inspiration. Again, you have your A2 coming first, and you have your P2 coming later. They're split no matter what. During expiration, there's a little split, and during inspiration, there's even more exaggerated split that's actually present here. That means that there has to be some type of pathology occurring that's causing the right ventricle to be under higher afterload, a prolonged period of depolarization, or the left ventricle is depolarizing quicker and earlier. So this has to be a wide split S2. So this is a wide split S2. This one was a paradoxical split S2 for the first one. And then for the second one here, this was a fixed split S2. All right, we didn't talk about the absent split S2 just because I feel like this is actually the most important ones to take away. All right, we tested your knowledge, we nailed it, we crushed it. Let's now move into the next part, which is the S3 and S4 heart sounds, which are extra heart sounds. All right, so let's now talk about the next thing, which is the extra heart sounds. So we've gone through the location. We talked about S1, S2, loud, soft, S1, S2. We talked about splitting of the S2 heart sounds. There's an extra types of heart sounds that you need to be aware of that you can sometimes hear physiologically, but it also could be pathological. And these are your S3 and S4 heart sounds. Okay, so S3 heart sound. The way that I want you guys to quickly understand these extra heart sounds is we have to briefly go through some of the parts of what's called ventricular diastole. There's actually 3 phases in it. So during ventricular diastole, we have it represented here. So again, let's actually remind ourselves here. This big black chunk here is going to tell me I'm actually going to test you. This black bar here is representing the closure of the mitral valve and the tricuspid valve. Which sound is that one? S1. I know you guys all said it good. Okay, then we have here, this is the closure of the aortic semilunar valve and the closure of the pulmonic semilunar valve. This is the S2, good. And then, again, we go back into S1. So if I were to test your knowledge here, from S1 to S2 is the period of ventricular systole, and then from S2 to S1 is the period of ventricular diastole. So ventricular systole is when the ventricles are contracting, injecting blood. Ventricular diastole is where they're relaxing and receiving blood. Simple, right? So between S2 to S1 is where you're going to hear these S3 and S4 heart sounds. So they're only considered to be diastolic types of extra heart sounds. That's important to remember. You do not hear it during systole. You only hear these S3 and S4 heart sounds during diastole. But in order to understand where we hear them, we have to have the different periods here. Okay, so this is what's called the early diastolic filling, which is the pink color here. So we'll write that down here. This is the early diastolic filling. So early diastolic filling phase. This is when there is a rapid entry of blood. Okay, rapid entry of blood into the heart. Okay, remember that. Early diastolic filling is when there's rapid entry of blood into the heart. The next one is the purple. This is called the mid diastolic filling phase. So this is called mid diastolic filling phase. This is where there is a slower entry of blood. Blood is starting to really kind of like already move into the right atrium, into the right ventricle. It's more of like a conduit. So think about blood that's in the right atrium. Think about this in here. This is actually a good way to think about it. Think about in pink, all this blood that's inside of the atria, that's sitting and waiting there to flow into the ventricles. This is your early diastolic filling. And it's rapid because it's just waiting in the atria to flood down into the ventricles. All of the blood that is in the channels here, like the superior vena cava, inferior vena cava, and some of the vessels outside of the pulmonary veins here, these are going to rush in after the blood from the atria dumps in. So this would be your mid diastolic filling. It's a little bit slower, but it's usually from the channels that are coming outside of the atria. And then last but not least, if there's any remaining blood that's sitting in the atria, at the end of ventricular diastole, the atria contract and push down the remaining 10 to 20% of the blood that's sitting in the atria. And so this is actually called the late diastolic filling, but we actually call this the atrial kick. So this is called the atrial kick. So this is when the atria actually contract and push remaining 10 to 20% of blood into the ventricles. Okay, so that's important to remember. The S3 heart sound only occurs in the rapid phase of ventricular filling. So this is in the early diastolic filling. That's why it's really important. So S3 would only really occur in which one of these phases? It would only occur here in the early diastolic filling. So this is going to be your S3 heart sound. That is important to remember, okay? The other thing that's important to remember about the S3 heart sound is not only does it occur during the early diastolic filling time, we should understand why it occurs during the early diastolic filling time and what kind of actual normal things can cause it to occur and what kind of abnormal things can cause it to occur. Okay, first thing is let's talk about the physiological reasons for this. So the physiological reasons for having an S3 is that you just have a high amount of venous return or a high type of compliance of the ventricles. So there's a high compliance of the ventricles. And particularly, we see this more in the left ventricle than you would in the right ventricle. But either way, it can happen in both of them. So what kind of situations would you have high, like venous return, where there's lots of volume of blood, but it's a normal situation? Pregnancy. In pregnancy, that generally these patients have to have a larger volume of blood because they have to have enough blood to pump throughout their body and the baby's body. And so pregnancy is a pretty common reason as to why they may have a higher amount of venous return, and generally their ventricles are a little bit more compliant to accommodate all of that volume of blood. You know what else? Young athletic individuals where they have good venous return and very good contractility of their ventricles, they're very healthy, and so they're naturally compliant. And so young athletes also tend to be a very common patient population that you can see these physiological S3 heart sounds due to their increase in venous return. So if you have a good venous return into the right ventricle or a good venous return into the left ventricle, during the early phase of diastolic filling, that is one reason. And also if the left ventricle can accommodate that and allow for that blood to flow into it, that's another reason. Now, why does this actually happen? Imagine the blood flowing down into a lot of blood, either high venous return or having a large space for the blood to actually enter in. When that happens, blood can run down here and it can actually kind of go through this like turbulence. And when it runs through this like turbulent type of process, it can actually give off a certain type of heart sound, because that's really one of the reasons for heart sounds and heart murmurs is turbulence of blood flow. So imagine right when the atria allow for blood to flow from the atria into the ventricles, a rapid volume of blood flowing down is going to create a lot of turbulence within those ventricles, and that's going to give off a vibration, which is going to come into the chest as the S3 heart sound. So that's the reason why. It's due to rapid ventricular filling within compliant ventricles or a rapid venous return into the actual ventricles. That's physiological. What are some pathological reasons for an S3? So pathological reasons is really kind of going to the same kind of concept, except it's not really like a high venous return. It's not really a high compliance of the left ventricle. It's usually due to excessive left ventricular dilation. So the left ventricles are like super dilated, and in that way they're very compliant, they're very floppy, they can accommodate, like, imagine having a big old like ventricle that blood can rapidly flow into. If you have a big space where blood can flow into, it's going to have enough opportunity for it to create a turbulent flow. And so what are situations where you have large amounts of very, very large left ventricles? This could be seen in situations like aortic regurgitation, mitral regurgitation. You can see this in what's called dilated cardiomyopathy, and you can see this in what's called systolic heart failure. In these situations, you may see commonly a patient with a S3 heart sound. The next thing to think about is not only will you hear it during the early phase of diastole, so right after the S2, it's due to rapid ventricular filling creating a turbulent flow. Physiological cases is pregnancy, young athletes. Pathological cases is left ventricular dilation. Aortic regurg causes a lot of blood to stay within the ventricles or flood back into the ventricles, so they get a large volume, they dilate. Mitral regurg, you pump blood from the left ventricle into the left atrium, it comes back down to the left ventricle, it gets volume overloaded, it dilates. Dilated cardiomyopathies within the name, there's dilation of the left ventricle. And in systolic heart failure, it loses its contractility and its contractility decreases. And so the actual ventricles kind of balloon up and become more like large. And this can be seen in systolic heart failure where you get the heart actually gets congested with blood. In these situations, you want to understand two things. When you're listening to this actual heart sound, it's really important to remember that the pitch, the S3 heart sound is a very low pitch. And so because of that, it's easier to pick it up with, there's two parts of the stethoscope. You know, there's the diaphragm of the stethoscope and the bell of the stethoscope. The bell of the stethoscope is actually good for being able to pick up lower pitch types of heart sounds. So because it's lower pitch, it's better heard with the bell of the stethoscope. That's an important thing to remember. Okay? And the second thing that you want to remember here is not just this, but when we listen for this one, usually it's more common on the left side of the heart. Left ventricle. And so when you actually put a person in, you can listen at the left lower sternal border, like around the left fifth intercostal space, midclavicular line, like near the mitral area. But if you put a person on their side, what's called the left lateral decubitus position, it brings the mitral valve closer to the actual chest wall. And when blood is rapidly flowing from the left atrium into the left ventricle, it's really close to the heart. You can actually accentuate those murmurs, this S3 heart sound. So it's actually heard very well in what's called the left lateral decubitus position. So that's something I really want you guys to remember for this, okay? All right, we talked about the S3 heart sound. Early rapid filling is when it's going to occur, right after S2. Again, it's going to be due to some increased volume of blood moving into the ventricles. A rapid ventricular filling creates turbulence of blood flow. It can be physiological in cases of high venous return, high compliance, pregnancy, young athletes, or excessive left ventricular dilation like aortic regurg, mitral regurg, dilated cardiomyopathy, and systolic heart failure. It's low pitch, best heard with the bell, and again, left lateral decubitus position is the best position to actually hear this in. Okay, let's talk about S4. All right, so S4 heart sound. This one's a very interesting heart sound as well, okay? So again, go back and remember, what did we say? There's what's called S1, closure of the mitral and tricuspid valve. And again, over here, we just have another S1, closure of the mitral and tricuspid valve. When S1 starts, until it gets to S2, is the onset of ventricular systole. Ventricular diastole is going to be, again, onset of that is going to be triggered by the closure of the aortic valve, which is the A2 component, and the closure of the pulmonic valve, which is the P2 component, but together we just call these the S2, right? So combined, really, we say this is the S2. Once S2 starts, from that until we get to S1 is ventricular diastole. There's 3 phases I told you I want you guys to remember. The first one, which is the pink one, was the early diastolic filling time period. Early diastolic filling, and I just want you to remember a big term, rapid filling of ventricles. Then you have the mid-diastolic filling phase. And again, this is the slow filling. It's really the conduits from the vena cava and the pulmonary structures. And then last but not least is the atrial kick. Okay, so the atrial kick is basically going to be when the atria push blood down. About what remaining percentage? About 10 to 20% of the blood is pushed down into the ventricles. And this is due to atrial contraction. Because the atria has to contract and push that blood down. So if we were to think about that, where would the S4 heart sound occur? Well, the S4 heart sound is actually going to be whenever the ventricles are really stiff, very, very tough, and difficult for them to actually fill properly. And we'll talk about what reasons that can happen. But in the S4 heart sound, the problematic issue, the phase, is actually going to be within the atrial kick component. So within the S3 heart sound, it was during the early diastolic filling was the actual issue. In patients with an S4 heart sound, it's during the last phase of ventricular filling, the atrial kick phase. And so when we actually listen for an S4 heart sound, it's actually going to occur in this last part here. So this would be early, mid, and this would be late. And this will be our S4 heart sound. So you can already tell the difference between S3 and S4. S3 would be early diastole. S4 would be late diastole, okay? So that's an important thing to remember. It's occurring during the atrial kick. All right, so the question that we have to ask ourselves is, why is this atrial kick becoming more intensified, basically is the reason. So that's kind of what's happening, is that there is an increase in the atrial kick. So let's actually write that down. In this situation, the reason why this patient is having this S4 heart sound is there is an increase in the atrial kick. And the reason for the atrial kick is that there is an increase in the left atrial hypertrophy. So that bad boy is it's working out, okay? It's working out, it's working hard, it's getting thick. Hypertrophic type of left atrium can contract harder and generate more force and increase the intensity by which blood is flowing from the left atrium into the left ventricle. That sound, when after the left atria contract and squeeze blood down into the left ventricle, is going to be giving us that S4 heart sound. So it's the degree of left atrial hypertrophy and the degree of left atrial contraction that determines our S4 heart sound. So we have to think about reasons as to why this left atrium decides to go, Arnold Schwarzenegger and get super jacked up. What would be some particular reasons of why that would happen? Well, let's think about this. What if I have a very, very stenotic valve? I got a valve here that's being pesky and it doesn't want to open up and let blood flow through. So I want blood to naturally go from my left atrium into my left ventricle. But this valve is restricting that process. It's super fibrotic, and now because of that, my left atrium is going to have to get thicker, stronger, because it's going to have higher left atrial pressures. When it has higher left atrial pressure, it'll increase to what's called left atrial hypertrophy. So that's that process there. And then when it has that left atrial hypertrophy, whenever it comes time period for it to go ahead and contract, look how thick this bad boy is. It's going to generate more force to push blood down into the left ventricle. And that's going to give that atrial kick intensification, which is going to give you the S4 heart sound. So what would be particular reasons? One of the reasons would be mitral stenosis. Mitral stenosis. All right, what's another reason? Another reason this can occur is imagine this left ventricle. Your left ventricle is super hypertrophic. So now it's going to be the opposite situation here. So let's actually do this in a different color here. So you have increased left atrial hypertrophy. So there's other reasons why this can occur. One is because of the mitral stenosis, right? But the other reason this can occur, this left atrial hypertrophy, just to have a different component here to explain it, is now imagine that the pressure inside of the left ventricle is really high. So high left ventricular pressures. So meaning that it's difficult, the left ventricle pressure is really, really high. If the left ventricle pressure is really high, that means that the atria is going to have difficult times of being able to fill the actual ventricles. Because again, we want pressure, whenever blood flows from one direction to another, we want it to go from areas of high pressure to areas of low pressure. When the ventricles are relaxing, so we can actually call this what's called the left ventricular end diastolic pressure. At the end of diastole, when they're supposed to be relaxing, their pressures are higher. And we'll talk about reasons why these pressures would be higher. But if it is higher, that means that the atria, they're generally lower pressure systems. In order for the atria to have to be able to push the blood down into the ventricles against this high pressure ventricle, it's going to have to bulk up. And so what happens is this high left ventricular end diastolic pressure leads to the left atria having to hypertrophy, because they're going to have to jack themselves up to generate higher pressures so that they can push the blood down into the ventricles down a concentration gradient. Imagine the pressure in the atria is like 20 and the pressure in the ventricles during rest is 50. Can you push the blood down that direction? No. So then the left atrium has to jack its pressure up enough that it can be higher than the pressure in the ventricles to push blood down. So that's what it does. The high left ventricular end diastolic pressures cause the left atrium to hypertrophy, and that's going to intensify that atrial kick. What are things that increase the left ventricular end diastolic pressure? Because that's the issue. This could be due to hypertension, because if you have high pressure out here in the aorta, the left ventricle has to thicken to push blood out into it to generate more force. If you have aortic stenosis, you have a very stenotic valve. You have to cause the left ventricle to get thicker and stronger to generate enough force to push blood through that small little opening in the stenotic valve, right? These could be particular reasons. Another one is, imagine you have like a fat septum that's occluding blood flow through that small area. And now you have to generate enough pressure to push as much blood as you can through that little narrow area. This is called hypertrophic obstructive cardiomyopathy. And there's many other reasons that this can happen. What if there's some type of process where the ventricles are so tough to fill that it actually can present as a heart failure type of symptom? You know, in patients who have what's called ischemic cardiomyopathy, this is a condition in which they have multiple infarcts of their heart. And whenever they have infarcts, they replace that damaged myocardial tissue with fibrous tissue. And if you have lots of fibrous tissue within the heart, is fibrous tissue going to be good at distending and expanding and allowing for you to stretch and accommodate volume of blood coming into the heart? No! And so because of that, it's so stiff, it doesn't allow the ventricles to open up. And if they can't open up and actually distend and accommodate blood, the pressure inside of them go up. And that's going to cause, again, the left atrium to have to bulk up to increase its pressure. When it hypertrophies, when it contracts, and it creates a large S4 heart sound. So this could be particular situations to remember and think about. Okay, next thing I want you guys to remember, just like the S3 heart sound, for the S4 heart sound, the other thing you need to remember is that S4 is low pitch. So what would be easy to hear this with? The bell. Listen with the bell of the stethoscope. And then again, the other thing is that it's actually going to be best heard in the left lateral decubitus position, because you get that left side of the heart mitral valve closer to the chest wall, okay? Let's test your knowledge. Let's see if you guys understand this now. So you have a patient, let's say that you're listening, again, at the left lateral decubitus position, you're listening with the bell of your stethoscope. When you have them in that position, you hear a low pitch type of heart sound, really in the early phases of diastole, the early phase of diastole. And when you hear this, you know that the patient is pregnant, or you know that they're a young athlete, or you know that they have causes of left ventricular dilation. You would say this is rapid ventricular filling due to a very compliant left ventricle or dilated left ventricle. Ooh, that is a S3 type of heart sound. Then I have another patient. I'm listening with the stethoscope, particularly the bell of the stethoscope. I'm listening in the left lateral decubitous position. It's a low pitch murmur. When I hear it, I'm thinking, ooh, this is actually what phase of diastole? Ooh, this is in the late phase of diastole, right before the onset of S1. If that is the case, I know that this has to be due to some type of high left atrial pressure, which is causing left atrial hypertrophy. This could be due to mitral stenosis, or it could be high left ventricular end diastolic pressures, where the ventricles are really, really tough and very, very thick and not wanting to fill or be compliant. Ooh, that could be to hypertension, aortic stenosis, hypertrophic obstructive cardiomyopathy, or ischemic cardiomyopathy. Ooh, that's an S4 heart sound. The big thing to remember is S4 heart sounds are always considered to be pathological. S3 heart sounds could be pathological or physiological. Now that we've hit this home, let's talk about a couple extra additional heart sounds that you can hear during systole, diastole, or throughout systole and diastole. Let's now move into some additional types of systolic heart sounds. We obviously know S1, we know S2, the changes in intensity in the S1 and S2. We know splitting of the S2. We know the extra heart sounds S3 and S4. Is there anything else that I can possibly hear, Zach? Yeah, we still have to do a lecture on murmurs in the future, but yeah, there's actually a couple extra types of sounds that could be present in systole or in diastole, or even throughout the entire systole and diastole, that we actually have to know for your exams or for the clinical scenarios. So first things first, in systole, you can actually get something called ejection clicks. Okay, so you can get something called ejection clicks. That's an important one to remember. So with ejection clicks, what's actually happening is we're going to take two particular vessels. Here we have our pulmonary trunk, which we're taking from here, and here we're taking the aorta, which we're taking from this position. In the ejection clicks, this is obviously occurring during ventricular systole. And ventricular systole would be the onset during what part? Would it be right after S1 until you get to S2, or would it be from S2 until S1? It'd be from S1 to S2. So we know from here to here for S1, and again, here's the other S1, and this is S2, which is the A2 component, the P2 component. From here to here, I know is ventricular systole. So the ventricles are going to be contracting on the left side, they're contracting on the right side and pushing blood up to the pulmonary trunk, pushing blood up into the aorta. If we were to really zoom in on that and see what's actually happening, it's really interesting. So imagine the right ventricle is pumping blood up here into the pulmonary trunk. When it pumps it into the pulmonary trunk and you have a patient who has what's called a pulmonary stenosis, they got a really stenotic valve here. Okay, so this is a patient who has what's called pulmonic stenosis. They have a very stenotic pulmonic valve. When you push blood into them, their valves are very, very fibrotic, sometimes even calcified. It's difficult for them to open, right? That's the whole problem. It's difficult for them to open and allow forward flow. So what happens is they actually do something really weird. I'm going to draw this with a dotted line. They actually kind of like do something called a bowing. They kind of bow. So imagine they're in this position. You push blood into them. You want them to snap out this way. You like them to go like this, close to the actual wall of the vessel. But instead, imagine them like this and then bowing, okay? When they bow, here's the opening. Here's the opening. This is what actually happens. They actually go from this position like this to this. And when they do that, every time you contract and push blood up into them and they bow, it creates a clicking sound. So going from this position where they're like this to bowing like this, this is called a bowing of the valve. That's going to produce a very distinctive clicking sound. And that can be heard during pulmonic stenosis. So again, imagine it like this. Here's your valve like this. Okay, here's the opening. You want blood to flow through here, right? When you want that to happen, you want this valve to open like this. But instead what happens is it actually does something like this. It bows. So it goes from this position to this position. And that bowing is enough to be able to produce a clicking sound. Same kind of concept can happen here with aortic stenosis. So here we have our left ventricle. We're trying to push blood up through the aorta. We want to push it up through the aorta. We want this bad boy to open. What would it, realistically, we want it to look like this. We want it to open like this so that blood can easily flow out. But in a patient who has aortic stenosis, that valve is not good at being able to open like that. And so instead of it opening like that, guess what it actually does? So imagine here again, we have a patient who has what's called aortic stenosis. They're going to get this bowing. So imagine here we have our aortic valve. We want it to open like this, but it doesn't. Instead, it actually bows. And that bowing of the valve, going from here to here, that bowing is enough to produce that classic clicking sound. Now the question is, when would I hear this clicking sound? I know it's during ventricular systole. Is it during early to midpoint, or is it from mid to late point? Because that's really the 2 points of where this can occur. And that's a good question. This clicking sound, which you may hear in these patients, could actually occur in the early to midpoint. So we're going to call this the ejection click. And again, there could be the pulmonary or there could be the aortic component of the ejection click. Here, just to make it look cool, we'll put ejection click. And this is representing the clicking due to the stenotic aortic valve or the clicking due to the stenotic pulmonic valve. So you would hear this in the early to midpoint of ventricular systole. And the other interesting point is that usually precipitates a murmur. So whenever you bow the valve, blood is going to try to flow through that bowed valve, and there's going to be a lot of blood that flows through and then less blood. And then again, that creates this weird type of murmur here, which we're going to represent here in black. This is going to produce what's called a crescendo, decrescendo type of murmur that you would see with pulmonic stenosis and aortic stenosis. That's one of the big things. Why am I mentioning all of this? Because we're going to talk about this in murmurs. Well, the big thing to do and understand here is that this can be somewhat different from another type of clicking sound that you can hear during systole. This is actually due to mitral valve prolapse. So you know a patient who has what's called a mitral valve prolapse. They also call this Barlow syndrome, floppy valve syndrome, a lot of different reasons for it. But usually what happens is there is a weakening of two tissues here. There's maybe weakening of the chordae tendineae due to connective tissue defects, right? So this can sometimes be associated with what's called Marfan syndrome. It can sometimes be associated with Ehlers-Danlos syndrome. So there can be weakening of that chordae tendineae, which helps to anchor down the leaflets. All right, so those are weak. They're not holding onto the leaflet. Now the leaflet's just kind of like, jiggling around. It's floppy, all right? The other situation here is that you can develop something called myxomatous degeneration of the mitral valve leaflet. So now this leaflet is all degenerated and actually weak. And so now imagine pushing blood against that leaflet to snap shut. It's super weak type of leaflet, and you don't have a strong chordae tendineae anchoring it down. When you actually contract and push against that leaflet, it's going to bow upwards. And so what actually starts to happen here is it starts to look something like this. It'll actually bow upwards into the left atrium. And when it bows upwards into the left atrium during ventricular systole, so when it goes from this position, so let's imagine here I have like in a dotted line, it was like this originally. Okay, it goes from here to here. From that position where it was in normally, during ventricular systole, when I'm trying to push blood out of the heart, this valve is supposed to close. It's so weak because of the weak chordae tendineae or the weakened valve leaflet, it bows into the left atrium. That right there, that bowing of the mitral valve produces a clicking sound. But the question is why, where would this actual clicking take place? Would it occur in the early phases to about the mid phase? Would it occur in the mid to the late phases? That's a great question. And this actually tends to occur more in like the middle to later systolic phases. So this would be your mitral valve prolapse type of click. Okay, and then here's the other interesting thing. So again, what would this be associated with, mitral valve prolapse? It would be the chordae tendineae are weak. Or it would be the leaflets are weak. And because of that, whenever ventricular systole occurs, it bows that actual leaflet inwards, which creates a clicking sound. When that happens, now think about this valve here. So get rid of this one. Well, actually here, we'll keep it just for representation. We'll keep it here for representation. But imagine now that leaflet is bowing up there. Is it going to be able to nicely click with this actual other valve leaflet? No. And so blood can easily regurgitate back into the left atrium. And so this may also produce an associated murmur that you can hear as well in the later phases of systole. So one of the big things to think about for aortic stenosis and pulmonic stenosis is these ejection clicks occur in the early systolic time period. Mitral valve prolapse occurs in the mid-systolic time period. Aortic and pulmonic stenosis are associated with a crescendo-decrescendo murmur, and mitral valve prolapse is usually associated with a mitral regurg, kind of a holosystolic murmur. It may have a little crescendo fashion to it, but it's usually in the later phases, and there's maneuvers that we can do to change that. And we'll talk about that in the heart murmur lecture. But these are the things that I want you guys to remember. So extra clicking sounds that you can hear is mitral valve prolapse, mid-systolic click, aortic and pulmonic stenosis, early systolic click. There's one more thing that can also cause a systolic click that we didn't talk about. Prostatic valves. So I want you guys to also remember that if a patient has something called a prostatic valve, it's actually normal for them to have a clicking sound. We actually want to hear that clicking sound during S1 and S2. So in patients who have something called a prostatic valve, it is important to have clicks. It's normal to have clicks. But if at some point a patient has a prostatic valve and the click is absent, we know that there could be a potential prostatic valve malfunction. So there's three scenarios what I want you to remember, clicking types of extra heart sounds. This could be aortic stenosis or pulmonic stenosis, so just those stenotic lesions, a mitral valve prolapse, or a prostatic valve. These are the things I want you to remember. Now that we talked about those, let's talk about some additional heart sounds, particularly diastolic heart sounds that I want you to remember. So what are these additional heart sounds? So we talked about the systolic ejection clicks, aortic and pulmonic. We talked about mitral valve prolapse. Early is going to be the aortic and pulmonic stenosis. Mid, mitral valve prolapse. And if it's prostatic valve, you should always hear the click. If you don't, it's prostatic valve malfunction. Additional diastolic heart sounds that I want you guys to remember is particularly these things called opening snaps. Okay, they're called opening snaps. And so this actually happens particularly in patients who have mitral stenosis or tricuspid stenosis. So you know what happens is during diastole, blood is supposed to flow from the atria into the ventricles. That's what's supposed to happen, right? The ventricles are supposed to be in a relaxation state. They're supposed to be opening up and allowing for blood to rush into them. So this is called ventricular diastole. And to understand diastole, we have to go through the heart sounds again. This is S1, this is S2. I'm sorry, S1. Sorry. This is the closure of the mitral valve and the closure of the tricuspid valve, S1. This is S2, which has the A2 component, which is the closure of the aortic valve, and the P2 component, which is the closure of the pulmonic valve. Ventricular diastole starts from S2 until you get to S1. That's ventricular diastole. So what happens is during S2 to S1, I'm going to hear some type of opening snap is the whole thing I'm talking about here, this extra heart sound. We already talked about the S3, the S4 heart sound that we can hear in this, but now there's another additional heart sound that you can potentially hear, and this is the opening snaps. So opening snaps are usually due to two situations here. One, more commonly, is a patient who has something called mitral stenosis. Okay, we'll talk about that here. The other one is a patient who has something called tricuspid stenosis. So what happens is they have these fibrotic valves, super fibrotic calcified valves, both of them. They got fibrotic valves, right? And these fibrotic valves don't really want to open very well, but blood is supposed to move through these valves and into the ventricles, right? The left ventricle and right ventricle respectively. What happens is when you want to push blood from the atria, so let's say here's the atria down into the ventricles, you want to push blood from the atria down into the ventricles, what you have to do is generate a high amount of pressure. And when you increase the pressure inside of the atria to push blood down in the ventricles, it's enough that it causes these valves to just quickly create a little snapping sound because they're under such high pressure to push them open that it quickly snaps. So imagine it like this, right? So imagine I have this valve here. Imagine I have this valve and I'm trying to push, and the moment it clicks open just a little bit, even if it clicks open a little bit, that's going to produce a opening snap sound. So that moment that these click open, it creates something called a opening snap. Okay? That opening snap can be heard, and we have to know where exactly would we particularly hear this. Well, it's going to happen right in the beginning of diastole. So if I were to say it's right in the beginning of diastole, it would have to occur like right here. So that's an important thing to remember. So let's actually draw this in here. Let's do it in black here. We're going to say that right here, I'm going to have a opening. I'm going to represent with OS, opening snap. That is that sound due to the mitral valve or the tricuspid valve popping open from the high pressure in the atria trying to push down into the ventricles. Here's the big thing that you can see and associated with this. When the blood flows down through that, imagine it like this. I'm generating as much pressure as I can. I pop them open. Once that thing is open up enough a ton of blood is going to flow through that. And it's going to be, little blood will actually flow through over time. So it's going to be a ton of blood at first and then less blood over time. So what you'll see here is you'll see like this opening snap and then a high pressure of blood flowing through, but it's going to be decreasing over time. This is actually called a decrescendo diastolic type of murmur that you can see associated with it. It's a rumbling sound. We'll talk about that in heart murmurs. But that's one of the big things to think about here is, again, mitral stenosis and tricuspid stenosis, you hear this opening snap right after S2. And when you'd be like, oh, how do I differentiate this from S3 and S4? Well, you would hear the snap, and then you'd also have an associated diastolic rumble after that. That's one of the big things to think about. Okay, another one that you can hear is called the pericardial knock. So what is this called? The pericardial knock. Son of a gun. So the pericardial knock is a really interesting one. You see this particularly in a condition called constrictive pericarditis. So what is this due to? It's due to a condition called constrictive pericarditis. Excessive amounts of fibrosis of the pericardial cavity. When there's lots of fibrosis of the pericardial cavity, think about this. This is during ventricular diastole, right? So your ventricles are supposed to be filling with blood. So if they're supposed to be filling with blood, they should be relaxing, trying to relax, right? But they got this rigid pericardium that's blocking them from relaxing, and blood's supposed to move into the ventricles from the atria. And a patient who has constrictive pericarditis, when the ventricles want to relax, imagine them trying to relax and then just being stopped by a rigid pericardium. So they're only going to get a lot of blood flow coming into them during the early phases of diastole. And so it's going to fill the ventricles up really, really quickly, and then boom, they're going to stop. So there's going to be a sudden rapid flow of blood into the ventricles because they're going to have at least some space, but it'll rapidly flow into them. The ventricle is going to try to expand to allow for more blood to come in, but then they're going to be hit by like a rock solid pericardium. They can't expand anymore. Because they can't expand anymore, there's a sudden cessation of blood flow. And that produces this pericardial knock. And again, since it's occurring during what phase? The early diastolic filling time. Where would I see it? Right here in the early point, right around the same time as the opening snap. So if I were to see this, I would see the pericardial knock that would occur right here in the early phases of diastole. But would there be an associated murmur after that? No. And usually if you compared this to something like an S3 heart sound, you'd be like, oh, how do I tell the difference? It might actually be very difficult. Technically, the pericardial knock is a little bit higher pitched in comparison to an S3 heart sound, which is a lower pitch. So you may not be able to hear this when you put the bell of the stethoscope on in comparison to S3. So that's some of the things to think about. Okay, we got the pericardial knock, and we got the mitral stenosis and tricuspid stenosis producing the classic opening snap. So you can hear ejection clicks during systole in addition, right? You can hear opening snaps in diastole or a pericardial knock. The last one that I want you guys to remember is something called a pericardial friction rub. So what is it called? It's called a pericardial friction rub. So pericardial friction rub. So this one's really interesting. So you can see this in patients who have what's called pericarditis. And in pericarditis, there's an inflammation of their visceral pericardium and their parietal pericardium. And whenever the ventricles are going through their periods of contracting and then relaxing, contracting and relaxing, contracting and relaxing, we're just going to keep doing this, contracting and relaxing, it causes the visceral layer and the parietal layer to rub up against one another. And whenever that rubs up against one another, it produces like a Velcro, kind of like ripping apart or scratching type of sound that you can hear in all phases of systole and diastole. So if I were to actually listen to this, and again, this is not just in the actual ventricles, you would actually, because again, this also surrounds the atria too. So you would hear this during the atrial systole, you would hear this during ventricular systole and ventricular diastole. It's actually called a triphasic. So sometimes we call this triphasic heart sound. Because, okay, let's think here. This is S1. This is S1, which is the closure of the tricuspid and the mitral valve. This is S2 with the aortic component and the pulmonic component that are closing. If it's continuous, that means it has to happen throughout all of this entire process from ventricular systole and ventricular diastole, right? So throughout this time period, ventricular systole, I'm going to see this scratching type of sound here, okay? Then after that, I have S2, which starts the onset of diastole. So ventricular diastole, I'm going to have all of this scratching sound. Remember I told you that there's one more thing, and that's when the atria are in systole. So during atrial systole, you may also hear like this scratching type of sound on top of that. So this represents a triphasic scratching sound that you can hear during ventricular systole, ventricular diastole, and atrial systole. Ninja nerds, we done did it. We done covered a beast of a topic, and that being heart sounds. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.